Would like to kick us off on our work session this afternoon, I would appreciate it.
Thanks, commissioners. These work sessions are for information purposes only, and there's no decisions that are made at them for the public that are listening. I would like to introduce Michelle Spreer, our HR manager. And the topic of this work session, and I may not be able to restrain myself and may have to comment here or there, as the former plan administrator for our health plan, is to just kind of give the commissioners an overview on our current health plan and what we're looking forward to as we begin renewal conversations, and then also some big picture conversations about what our plan is like now and what we should be thinking about for the future in terms of where our plan should be headed. So with that, Michelle, I'll turn it over to you.
Okay, I am usually not the presenter on these, so bear with me as I try and share my screen here. Okay, are you able to see my screen?
Yes, thank you.
Good. Okay. All right, so like Sarah said, we'll just do a quick overview. We'll look at where we're at with some claims dollars, some total plan cost from the June 1 start date. Our plan runs from June 1 to May 31 every year. So we'll look at some numbers. We only have data really up through March or January 31st. So with that, let's see. So our total plan cost right now, and so total plan cost would be all of our claims for medical, dental, prescription. It would include any like admin fees, stop loss fees. So we're running at about 86% of projected right now. So it's looking pretty good. We don't know if part of the reduction may be to delayed care because of COVID. I think things have opened back up and people have, had those surgeries and procedures that they delayed for a while, but we don't really know that. As far as just medical claims, they're down nearly 9% from the same time last year after our stop loss adjustment. So that's a good thing. Again, we don't know, it could be COVID related. The plan has spent about $166,000 on COVID related expenses. So that would be any testing, office visits associated with ordering those tests, administration fees to actually administer the test. All of that's included in there. Stop loss premiums, those are up nearly 23%, which we knew it was a big renewal last year because we had we've had a few years of pretty high claims, claims that have hit the stop loss. Willis, which is our Willis Towers Watson, they're our broker, benefit consultants. They have helped us in lowering their commissions the last 2 years to keep us within our budget parameters because we have had such a high stop loss renewal. So that has helped. The premiums paid to date are $886,000 plus. Total reimbursements have only been about $33,000. So they're definitely making money off of us this year so far. That's a good thing. We've had one claimant hit the stop loss. Our stop loss limit is $195,000. This claimant also has hit it the last 2 plan years. This same time last year, we had reimbursements of around $500,000 in stop loss. So you can see we're running a lot better right now on stop loss. So fingers crossed we have a decent renewal, come June. So all of that, we've already started working on all those renewals and everything. So some other benchmarks based on funding rates. Douglas County covers approximately 75% of the total plan cost. 25% of that comes from employees. Of that 25%, 15% of that is their out-of-pocket costs. So your deductibles, your co-insurance, your co-pays, things like that.
Michelle, before you move on, just in case the commissioners have questions about what stop loss is.
True, yeah.
Okay, do you want to explain it?
Yes. So stop loss is actually, since we're a self-funded plan, everything that we pay for this plan outside of what employees pay in deductibles, and co-insurance and co-pays, it comes out of the city's, I'm sorry, I spent quite a few years at the city, comes out of the county's budget. But we actually buy fully insured insurance. So when our claim, if any one individual hits our stop loss limit, which is 195,000 right now, this insurance company will pick up and start paying. So if someone has $500,000 worth of claims, we're responsible for the first 195, and then they pick up the rest basically. So, and you pay a hefty premium for that when you do have a lot of high claims. So any questions about that? Does that make sense? Okay, all right. Prescription claims, similar to last year, we're about $1.4 million right now. Rebates are up. We've received around $284,000 in rebates. It's up 53% over the same period last year. When we were having this conversation last year, the rebates were up somewhere in the ballpark of 200%. MedTrack does a really good job. We kind of changed the way we handled rebates, or the way MedTrack, it's now called Elixir. That the mix of drugs that people take help determine the amount of rebates. Elixir does a really good job of negotiating with drug manufacturers. And then the county keeps 95% of the rebates they get. They keep 5% kind of as an admin fee. So getting those rebates has really ramped up over the last couple of years. Tria Health, it's a pharmacy advocate program. People that or members that are enrolled in this program, they get free or reduced price medications as long as they're compliant with the program. They keep their times for their phone calls. They have access to a clinical pharmacist, which might be a little different than the pharmacist behind the counter at Walmart or whatever. So these clinical pharmacists make sure they stay engaged, make sure they stay compliant with their medications. They let them know if there's cheaper medications out there that could provide the same benefits. So right now we have 223 actively engaged members. The cost for the plan in the 2020 calendar year was around $54,000, with a savings of $322,000, almost $323,000. So those savings could be cost avoidance. As long as I stay compliant with my meds, I'm not landing in the emergency room or in the hospital. They try and keep people on track. And then telemedicine, it's for Stop Health. It's no cost to employees or family members if you're enrolled on the healthcare plan. Utilization is about 38%. That's actually down from last year. I think it was around 48%, but I think it's because we made some changes to the actual healthcare plan due to COVID. Everything's due to COVID anymore. 87% of the visits prevented an in-person visit, so that saves everybody money. Cost avoidance of approximately $13,000 due to that 87% of visits that we've prevented. And then 96% of the visits have a 5-star rating. So the feedback on this is very nice. I've used this probably 3 or 4 times myself. If you're on our healthcare plan, it's a pretty cool plan. Employee education. So for the 2020-21 year that we're in right now, some of the things that we did, of course, we moved to a virtual or recorded open enrollment last May. I think that went over very well. So I'm thinking COVID has probably forever changed how we'll do this stuff. So I see us recording and doing virtual open enrollment probably every year. I like the in-person stuff too, but this is a viable option. We kind of formalized the new employee orientation a little bit. Of course, COVID dampened that because we were doing larger groups, getting people together from different departments. We've got PowerPoint. So we really kind of get into detail about the benefits that are offered to people and what kind of things are covered, and just to really try and educate them and give them the tools they need to make decisions on their benefits. We try and send some periodic emails about some of our more complicated benefits to help people understand how to use the plan. We've also enhanced the benefits page on the intranet and the county website. So you can get to it from home. So if you want to, you want to show some stuff to your family or whatever. So we've kind of made a benefits hub out of that. The medical and RX for this plan year that we're in, like I said, we changed the actual healthcare plan to include telehealth services, and due to the pandemic. Before that, if you wanted, you could not have a telephone call or a Zoom call with your primary care physician. Telehealth was, First Stop Health was your only choice for that. So we have added that. I think that'll be a permanent change as long as doctors' offices are still accepting that. I see us just keeping that on our plan as an option. We also kind of upgraded our coverage for nutritional and dietitian services, medications and surgeries related to obesity. This definitely is not an immediate plan savings. If anything, we may see a little more cost in our plan right out of the gate for stuff like this, but the goal is to avoid cost, bigger cost items down the road. So if I lose weight and I stop taking medications, that could save me from that heart attack or that stroke, that higher cost item. So we'll know more about the claims impact, after at least a year of claims, and then we'll monitor this every year as we go. So, and those actively engaged with Tria Health, we added 100% coverage for A1C testing. So if you're diabetic, you have to get that A1C test every 3 months. They can get that at no cost if they're compliant in the program. And then they can get 100% coverage for blood pressure and cholesterol and certain respiratory meds. Non-compliance, like I said, can be very expensive. So we'll see how that's going. We haven't really checked in on that yet this year, but as we start the renewal talks, we'll check in on how that program's going. And then for out-of-network claims repricing, most of our claims on our plan are in network. We do not have a lot of out-of-network, but we have seen a savings with this new method of repricing of $43,000, which we expected that savings. That's why we changed, or I guess Trustmark took care of that for us. Wellness program, we did a combined flu shot and biometric clinic. Prior to doing that this past year, we could go get flu shots on a certain day, or go to the pharmacies, and then biometric clinics was a separate event. We did combine those for kind of a one-stop shop, I guess. So I think the feedback was pretty good. So I hope to continue doing that every year. It saved us a little bit of money because we got our flu shots through LMH, and they give us a pretty good pass-through price on those. And then we added a follow-up visit through our wellness program. So you have to have so many points in order to earn the incentive. And so after you get your biometrics, which are, your blood draw and everything, most people would get their results and then that was it. You got your results and never really talked about it and followed up with anybody. So we did add a required visit with one of the nurse practitioners at the WellCare Clinic in LMH. They're health coaches. So they review your biometrics in detail. So I've received some pretty good feedback on that as well. So I think we'll just continue to build on that. Any questions so far? Good. Okay. I'll just keep rolling along. So as far as our 2021 renewal, I've kind of talked to Willis a little bit. Again, we're just kind of starting that process of doing projections and where we're at. A ballpark renewal would be a 5 to 7% increase in funding. Based on where we're at now, if we continue doing this well, I would hope for less than that. But time will tell. An increase in funding can come in the way of county funding. It can come out of increased contributions for employees and retirees. Increase in funding can come in the way of increased deductibles and out-of-pocket maximums. So there's all kinds of ways you can get to that 5 to 7%. And those are the things that we'll talk about with Willis. So we'll be coming back to you guys probably early to mid-April to review what we want to do for June 1st renewal. So we'll continue the ongoing employee education and communication. I think that is key, especially if we do want to make some plan design changes, which I'll talk about on the next slide. The communication is huge. Telling employees what a self-funded healthcare plan means. They pay their $25 or their $50 copay for an office visit, and then that's it. The plan might pick up $175. So what is the true cost of this plan? What are the total plan costs? I mean, you're looking at admin fees, stop loss fees. It's not just claims. So, educating employees on how much this plan actually costs every single year. Encouraging those preventive visits. Those are covered at 100% by the plan. We want people getting those visits. Flexible spending accounts, that saves everybody money. The county saved in the 2020 payroll year, we saved $23,000 in payroll taxes with people enrolled in flexible spending accounts. And so the employee saves money too, because the money they put into a flexible spending, they never pay taxes on. They don't pay income taxes on. So it's definitely good for everybody.
Michelle,
yeah.
Sorry. And then help me remember, what was our approximate renewal increase last year?
I think we ended at about 6% last year.
Okay. And then I think the year before we were closer to 9.
I think it was closer to 9 before I got here. Yeah. Before that. Yeah.
All right.
Yeah. Another thing I want to do, I know there at one time, and Sarah, may have some feedback on this. There was I think it was called the Personnel Advisory Committee, called PAC, that kind of got together to talk about healthcare. So I want to get that alive again in some form, maybe an actual healthcare committee where we recruit, someone from each department to come and be that conduit for information, and have stated goals and objectives. So everybody on that committee knows what their role is. And they take information back to their departments, and they bring questions from their department back to the committee. I think it could, I think it could work well. It helps, it just helps with that education piece. So.
Yeah, and to Michelle's point, previously we had both, we had a kind of a looser healthcare committee that really only met once a year. And we did have another group called the Personnel Advisory Committee that met on a more frequent basis, but they kind of overlapped and talked about similar things. So we've always had employee engagement in our self-funded plan, but not to the extent that I think Michelle's hoping to take us to, with a more formal committee with definite representation and some more in-depth knowledge on how the plan is structured. But I am pretty proud of the fact that we've always taken time to sit down with employees, department heads, anyone who's interested before the plan comes to the commission for a review and approval, to really walk them through the plan and present recommendations to the county commission as to how they think the plan should move forward. And, I think that's been a really positive thing for our organization, is to try to explain that, but I'm really excited for something a little bit more formal that I think Michelle has in mind.
Enhanced wellness program. Again, these are just, bigger picture ideas, nothing that we're planning on doing in 21. It's just, these are thoughts and ideas and topics to talk about. And, enhancing the wellness program, whether it be, an offsite clinic, employees could, if they want to stop smoking or they want to try and lose weight, they can meet with, the nurse practitioner at the offsite clinic and have unlimited number of appointments. It's a capped fee for service. So you can send, 4 people through in an hour, for $80. 4 people going through the healthcare plan for office visits is more like $500. So that the whole capped fee for service approach is why one would want to do, you know, an on-site or off-site clinic. So exploring that a little bit more, offering some financial rewards for participation and compliance. Right now, if you get the incentive for participating in wellness, it's 8 hours of personal leave, which I love. So, you know, maybe having choices on what kind of incentive you want to receive. So just ideas. You know, looking at outside agencies, you know, we cover all the townships, we have Burt Nash, we have the health department, you know, looking, you know, are these agencies paying their fair share? Again, I'm not saying anything needs to happen. I think we need to explore things. You know, when we open up our plan to outside agencies, I mean, that's more risk that you're bringing onto your plan. So you need to weigh those risks against the benefits. And then retirees over 65. Right now, our plan, you can stay on it indefinitely. You know, retirees, once they move over to Medicare at age 65, they have lots of options with supplemental plans that are far cheaper than our plan. Maybe not as rich, not as convenient as our plan, since it's all bundled together and you know what you get. But, you know, do we look at just having them go ahead and take a supplemental plan somewhere else? Web-based benefit enrollment platform. Actually, the implementation for that is underway now. We're working with Benefits Direct, which is our vendor for all of our supplemental benefits. They have a web-based enrollment platform that they can provide to us, where this will be the benefits hub. This is where you do your open enrollment. It is web-based, so you can get to it from home. So if you want to have conversations with your family, you know, whose plan do we need to be on, mine or yours, which looks better? Giving people the resources they need at their fingertips to make decisions about their healthcare. So I'm excited about getting this done. But it's looking good as far as right now, it'll be ready for open enrollment. So mental health, First Stop Health does offer virtual mental health visits. This is an extra fee because right now, if you use First Stop Health, it's just for acute care, you know, a rash or a sinus infection or, you know, small things like that. So, you know, maybe we want to explore what the virtual mental health looks like. Again, it's not a free service. So, you know, we have to weigh those costs with the benefits. Eap Education, reminding people that the employee assistance program is there. It is completely free to employees and their family members. They don't have to be covered on the healthcare plan to use it. It's a good starting point. You get 3 visits through that plan. So it could at least get somebody some help without worrying about covering the cost of it, which adds more stress to, you know, whatever they're dealing with. So.
Michelle, but maybe before you move on, if you could go back to that slide, just a little bit of background, and then commissioners will see this more as we come towards plan renewal. But, and correct me if I'm wrong, we probably have close to 800 employees on the plan.
We have about 750 employees, and then total belly buttons, so to speak, is around a little over 1,100.
And so of that 750 employees, roughly 450 are county employees. Mm-hmm. The rest are employees of Burt Nash, the health department, extension, and townships. And various townships. We pay their entire employer share. And so in the commissioner's budget, you know, under community partners in the budget, you'll see 2 lines for that. You see what our general subsidy for Burt Nash is, and then you see what our health insurance subsidy is for Burt Nash. So I think what you'll see when we come to renewal is we are able to track that information by group inside our plan. So we know if Burt Nash, since it's a self-funded plan, is paying their employees are using more of the plan than they're paying. Same goes for retirees. And I think that's just important in a self-funded plan where we can set our own renewal rates, or those conversations we want to have. is there, it's a pretty significant share that, you know, when you pay 75% of the total cost for health care. Also with retirees, I feel like just a little bit of background information. This is something that the county has done for a very long period of time. And it is a very rich benefit to continue. We have to cover people until they're 65, correct, Michelle?
Yes.
Make it available to them, but we heavily subsidize the program. They're not quite at the 75% subsidy rate. It's probably closer to like 55, if I remember correctly.
Yeah.
Michelle. But it's still, you know, so these are folks, they've retired, but we're continuing to subsidize their plan above what our requirements are before 65 and then after 65 when they have other options available to them. This is a very rich benefit part of the plan. And I think, you know, we just want to kind of plant this seed early on for new commissioners that as we approach plan renewal, you know, when you see the sticker shock of how expensive this program is, you know, that there are some things there in part of that. And I'd also say just my last piece on mental health, I told you I wasn't gonna be able to be quiet, in addition to what we talk about there, we've done some work over the last couple of years to really streamline how our insurance plan looks at a variety of different mental health services. So therapists, social workers, psychologists, psychiatrists, all that work. Oftentimes in a health plan, those are very siloed, but really sometimes a person just wants help. So we've done some things to try to put all of those providers together. We include Bert Nash in our pool, so employees can, we are a provider for them, and worked really hard to have a pretty robust network of a variety of different mental health providers in our portfolio. So I just wanted to mention that we have that as a base part of our plan, in addition to what Michelle mentioned with EAP and virtual mental health visits. So that's it. Thanks.
Okay, so my last slide, when we were talking this same time last year, we had thrown out the terms, you know, health savings account, HRA or health reimbursement account. And then, you know, COVID hit. Not that I want to blame everything on COVID, but to make some plan design changes, such as what you see on the screen with a high deductible health plan or an HRA, it is a huge communication campaign. It's a big shift on how things work, how claims process through the plan. In my opinion, I think you need to take a year of communicating and prepping before you do a full replacement of a, you know, traditional PPO plan like we have now. So what you see on your screen, you know, for the 2022 renewal, I can see us moving to one of these options. You see our current plan, and then you see the high deductible health plan that you would tie an HSA or a health savings account to. I would say that I'm not sure this organization would be ready for a high deductible health plan with an HSA. And there's a lot of changes that, you know, it changes the way you can offer a flexible spending plan. You can only offer a limited use flexible spending plan. That is even more education that you need to do. If you look at those deductibles and out-of-pocket maximums, they, you know, coming from the plan we're on now, they kind of take your breath away. You know, an HRA or a health reimbursement account on the far right, that would be more of a baby step, I guess, you know, to a possible HSA down the road. You know, but with an HRA, a health reimbursement account, and I can go into all kinds of detail about this, or I can just kind of hit the high parts and then we can talk a little bit more. Again, this wouldn't be 2021 renewal, but for 2022. But with an HRA, you know, it's still it's consumer driven. You know, you have you know, the county would put a little bit of seed money in there to help employees meet some of those first dollar deductible. I guess the biggest thing you want to look at on here, when you look at the very bottom line, the plan coverage differential, given our mix of claims, you know, kind of where we're running right now, what we look like right now, if we would put an HRA in place, that 6.7% negative 6.7% plan coverage differential comes out to about $600,000. So I don't know what the 10.8% is. I didn't do that math. I spent more time looking at the HRA, but I worked with Willis and they kind of crunched the numbers for us. So you can see, and we'll see what this looks like. We'll monitor claims as we go. And then if we want to recommend this for the 22 renewal, we'll see what that 6.7% looks like at that time. Maybe it's more or less. But I mean, I'll stop there. I don't know if Sarah wants to add or if there's specific questions. I just don't want to go into great detail about it if that's not what I need to do.
Yeah, I would add that we purposely showed you numbers here that would not be applicable for the next year. So please know that like that plan savings of 6.7 is something that we, would be if we did it today, which we're not recommending, but just to give you a sense of what it would look like. Also, it is highly likely that we will recommend some sort of deductible change or, in addition to just to where we currently are at $700 per person or $850 per family between now and then. So the gap between 700 and 1700 might get a little bit closer. Traditionally, what we've done over the last couple of years is we've done both plan design changes. So that means changing deductibles and then premiums. I always use air quotes because it's not an insurance premium. It's what we charge employees on a monthly basis to participate in the plan. And we do a little bit of both to come up with that 6 to 7% increase a year. I could anticipate that we would do that for the 21-22 plan year. And we don't need, obviously we can't make any decisions today. Commissioners, I'd love to have some conversation about where you think we should be headed. But I think it would be very important for us by the time we do the renewal in early to mid-April to know that the commission wants us to prepare for a 2022-2023 renewal with an HRA if that's the direction you want us to go, because it will take a year's worth of education to get us there. If you want more study, you want more information, like we can certainly continue to do that. But we just want to make sure no one is surprised about this kind of change. It's very important to their day-to-day lives.
That was the end of my slides. So I will open it up if we want to talk more and again, if the HRA is something we want to look at, I ran an HRA plan at my previous employer. I did spend a year communicating and campaigning. The rollout, I think, was very, very smooth. And people grew to really like the plan. You hear these numbers, we have probably maybe 15% of the members on the plan drive about 90% of our cost. I've always been a big proponent that if I'm going to increase funding, I would recommend putting it in deductible and co-insurance. And I don't want to sound cold, but if I am a big user of the plan, then I pay my part. Instead of making everybody pay out of their paychecks, when you've got 65% of the people on your plan that don't even get out of their deductible, they don't even meet a deductible in a given year. So I'm big on the deductible and co-insurance, and the HRA is nice because it gives a little bit of seed money down there at the bottom. So your deductible, is $1,750, but you can take a little bit off of that if you get a little bit of seed money. They call it consumer driven because that seed money, if I don't use that seed money, or maybe we have a wellness program where if I participate in wellness, I get a little bit more money in there. That's my financial reward. Then I don't use that money, it rolls over from year to year. So if I'm not a big user, I can roll that money over from year to year. And then when I do have that bad year come along, which I think we all have, I have a nice account built up to cover, a lot of my deductible. I think it's exciting.
Michelle, while commissioners are kind of thinking questions, if you want to stop sharing, I could direct commissioners to the open budget portion of our website where we talk about our employee benefits fund. And, it might, can you guys see that? So this is our open budget Socrata platform for our budget. I've clicked on our expenditures and here's where we come up to, and you see all of our funds. We have a separate fund for all employee benefits that does not include the contribution. So this does not include the contributions that we set aside for Bert Nash and the health department. They're on top of this. So one of our largest single expenditure in our budget is or for benefits for our employees. And you can see here, as you click on that, we can go through past years and see how that fund has grown over time. So in 2021, we estimate this fund will be, and this is all benefits. So it's not just health insurance, it includes CAPERS, KP&F and other things. And if you go over time, you can see how this fund has changed over time. And I just would encourage you to kind of take a look at how this goes. And part of the plan year conversations, and I think Commissioner Kelly will be tempted to talk about this when we have open dialogue. So because our plan year is sort of unusual with a June 1st start, the advantage is that when I'm working on budgets in April and May, I know what 5 months of my healthcare plan are going to cost. But I have to estimate the remaining 7. So it's actually not bad from a budgetary perspective, because at least we know that. If you have a traditional end of the year renewal, many times you're guessing at what your plan renewal costs are. But in our situation, what that forces in that situation is, hey, this is all we have to spend on healthcare. The plan has to live inside it. What happens with us is the first thing we take off the top is benefits. So the first thing I will come to you all with budget is, okay, of the available funds under the tax lid that we have for the upcoming year with appraisal, with additional increases in appraised value, is the healthcare plan comes off the top. So I think it's, in essence, I'm asking you to make decisions about next year's 2022 budget before you have any information as to what your revenues are going to be. And I think it puts the commission in a difficult position where you have to begin without any information and make a decision that will impact you in the next couple of months as you want to spend or reallocate funds for certain expenditures. So that context might be helpful as to why we spend a lot of time trying to talk about how to contain costs in this area.
So this is Commissioner Kelly. Could I ask the question I ask almost every year at this time? When you compare us to the other large employers in Douglas County, I know Michelle, you used to work for the city. How does our benefits plan, especially our health packages, compare with those other employers?
It's a rich benefit. That goes without saying. But, back to what I was talking to just a little bit ago about putting those, putting the funding into deductibles and co-insurance and out-of-pocket maximums versus premiums. And I can compare to the city. I haven't looked at other large employers. If you want to look out at private employers, this plan is just going to blow them out of the water. Government plans usually do. So that's not really a good comparison. But just for me, myself, I am paying $300 more a month out of my paycheck for my family plan here than what I was paying at my last job. But the deductible is a lot lower. But I don't use, knock on wood, I don't really use the plan. So, you know, that's why I'm paying that much more money for a plan I right now don't use. So, but yeah, it's definitely I was excited to see the benefits when I came on board.
And that's what I would say too. You know, one of the metrics that we try to monitor as we go forward, and I know Michelle will bring it when we talk about renewal, is, you know, at least even in local governments in the region, an 80-20 split from employer to employee is pretty common for local governments. So when I compare us to the Johnson County cities, 80-20 is actually pretty rich. And we sit at 25-75. So, you know, I think that, you know, I think trying to monitor that, how we compare in those, and I think Michelle can get some of those numbers and we can get some of them from Mark. You know, what do other employees pay and what are those costs of that plan? Are just some other important considerations for us to talk about.
Well, and if you look at the larger employers like, you know, Johnson County, they may have 2 or 3 different plans to pick from. You know, when I was at the city, we just had one plan. It's easier to administer. You know, we've talked to Willis, you know, when we talk about implementing an HRA, we've talked about, do we slice it and we offer the HRA and keep our PPO plan, or do we do a full replacement? Administratively, I'm all for full replacement. So you don't have to administer 2 plans, but it also doesn't necessarily, it won't always save you money, any kind of money to have 2 different plans, because theoretically you're going to have your sicker people, I don't know if those are the right terms, staying in that PPO plan with that low deductible, and then all your healthy people are jumping to the HRA. So it doesn't always serve you well to slice it up like that. And you don't want to make a move like, you know, pricing the PPO plan so bad that nobody wants to stay in it, because then it's, you know, you're throwing a stick at them instead of a carrot. So, you know, that's not always a good approach either. So.
This is Commissioner Reed here. Thanks, Michelle, for all of that. And thanks, Sarah, for giving a little bit of context or the breakdown of about how many employees Douglas County has in that pool versus, you said it's Burt Nash and then townships.
Health Department, Burt Nash, Townships, and the Extension Office, but you know, it's mainly Burt Nash and Health Department and retirees.
Okay.
So
maybe this question is best for Sarah. I don't know. I guess I'm just curious what the historical context of that is and how, because it sounds like quite a few people, therefore quite a large chunk of the spend down from the county's perspective. So I'm just curious.
So I think, to me, there's kind of there's 2 explanations depending on the group. So with the smaller groups like townships and extension, really most townships have, most townships have no full-time employees. Some townships have 1 or 2 full-time employees. It was just impossible when probably in the 90s, when, you know, standard, you know, healthcare for full-time employees became really just a requirement for employment. There was no way they could afford a one-off plan for just 1 employee. So there was a decision at those times, and all those happened pre the last decade I've been here, to just add them onto the plan. And now in the case of the townships, they pay the full employer cost of that amount. And I would say that and that happens in public plans. with smaller, if you have, a related entity that cannot just afford it, or can't even access coverage one-on-one, but oftentimes they pay the full cost. So, and in the case of the township, they pay the full cost. Extension does not. Part of our subsidy for extension includes the employer portion of two of their employees that are not able to be covered on the K-State plan. I think with Burt Nash and the health department, I think it was probably also done around those timeframes when it just was one of those decisions about, it was getting expensive to be fully insured. And the thought of, is this a way the county could assist the health department and Burt Nash and provide them assistance? I would say in my 10 years managing the plan, we did a lot of work to get them on a consistent plan type with what we offered, and we made a lot of progress. I have to say some of the Affordable Care Act reporting complicates this. If you're not their employer and you're doing offering the benefit, we have a whole set of additional regulations that fall on us that we have to accommodate. Not that we won't do it. I just mentioned that it's difficult. But along that line, and I do want to say this. So part of the reason why I mentioned how many employees we have on this plan, I almost want, and Michelle is free to offer, how many employees were on the City of Lawrence plan?
850.
So just a little bit larger than us. How many people are in their HR department managing this self-funded health plan?
I mean, they have an HR team of 9. Yeah. So yeah,
Right.
they have the resources.
So until we hired Michelle in 2019, yes, I was managing this plan on top of everything else I was doing. This is a heavy administrative burden. Managing these plans, Burt Nash's HR department is larger than ours, and they don't manage their own benefits. So I do think that as you think about how we manage this plan, please think about our administrative infrastructure and how we do that. Part of the reason why I have not suggested an HRA to this point, I could not have managed one on top of the duties I was doing. And I'll just admit that. And so I think that part of one of the many reasons we brought Michelle to this organization was her expertise in benefits administration and her ability to help us talk through these conversations about how you would manage this. But, offering 2 plans, like there's a lot of complexity here and we have a very small staff. So I know I went way off topic, Commissioner Reed, from what you asked, but I wanted to put in a couple of those pieces of information.
I really appreciate that, Sarah. And I think that, I garner so far in my limited experience that it is a tiny staff. And so when you said those numbers to me earlier, I was kind of taken aback by wondering what management of that looks like. And certainly understanding that if we're talking about a change, that a really intentional, planned out path towards that is necessary from both the communications and a logistics administrative roles. So that's helpful for me to hear. Do you have any sense of, since the townships and the smaller entities, that totally makes sense to me. Burt Nash and health department, that sounds like that happened before your tenure here. It feels like both those places have grown exponentially in their own staff.
One of the things that we've talked about in the past that I think the commission could entertain is, and this would be a dramatic change. So I would want to have conversations with the health department in Burt Nash. But we could, sort of cap our subsidy of what we spend. I think if I go back to, our open budget, I can show up here pretty quickly what we are spending by each of them on that amount. We could cap that and say, hey, here's our contribution, but you need to find coverage elsewhere and not administer them, or ask them to more fully contribute to the plan. I think I can share now if I've got it up, if you're interested. So this piece lies under our open budget, under our community partners page of the general fund. And health insurance for Bert Nash is approximately $1.8 million. And then our cash contribution is less than that. And then the health department, that's their regular, and I should say with the health department, their insurance amount is $296,000. That is because the city of Lawrence pays 40% of that cost. So this only reflects 60% of the cost of that plan. Lawrence picks up 40%. And
Sarah, on that one, does Lawrence pay anything towards the administration of the plan, or do they just pay the actual funding of the plan?
they do not.
'Cause we do have some I recognize we work with a very lean team, but we do have some administrative costs when it comes to administering that plan.
Correct. So
So
yeah,
so this is just this is just funding of the plan. This doesn't even look at, I mean, the risk that you're bringing on to the plan. I mean, right, you're bringing on, 400 more people. So that, I mean, that's a lot of risk on your plan.
correct. Yeah. Yeah. And inside, we don't break out the direct subsidy for retirees directly. That does hit the employee benefits fund. But that's, so it's a little harder to look at that. I think it's one of those things that just as commissioners, I think you're going to be continually sort of asked to address. How is it important that we try to control costs in this area? And if so, how do we do so?
This is Commissioner Portillo. So I have a few very controversial questions, and these are like big brainstorming questions, not let's go in this direction. But our community has had a number of conversations around city-county consolidation, which is obviously a very big thing. But one smaller aspect of that is often talking about kind of administrative infrastructure, and one piece of that is benefits and things like that. Is there any kind of, we already provide benefits for townships. Is there any kind of discussion with municipalities within the county, not just Lawrence, but also thinking about Eudora and Baldwin, to think about any sort of joint benefits discussion?
Before I let Michelle kind of answer some of that, one thing I would say is that I routinely, when I was in that role, was approached about once a year from a nonprofit, not necessarily a city. Because I think some of the smaller cities have access to some statewide plans that can help in some of those ways. But I was approached at least once a year by an area nonprofit and asked if they could buy into our plan. And when I said, well, you mean like you would pay the full cost, the employer cost of the plan, and the employee would pay the employee portion? And they said, yes. And when I showed them how expensive our plan was, none of them could afford it.
Well, and I think that part of that is being on a nonprofit board, having sat through the nonprofit side of these conversations, the benefits do look very different and the costs look very different. And so we do subsidize Bert Nash and public health in this way. Is that something where if we thought about nonprofits as a larger pool and we think about social services in our community, is that something where we want to extend that benefit to other nonprofits in our area?
I think we could if we changed our plan design. I think it's part of the way the plan is currently structured. It's really almost, it's going to be difficult for us to sustain financially. So I think it's a if we were to redesign our plan in that way, I think there are conversations around that could happen, and we've talked in the past before, think it would, there's a variety of factors, what would that mean? Would we have every time you add a group in, it's a lot more administrative overhead. So could we charge something that would allow us to have the staff to manage that? Simply the reporting alone, and then I have to say, like, we're a self-insured plan. So I think that's a little different too from what some nonprofits are used to. A self-insured plan means I have a question about my explanation of benefits, and I call Christy, and Christy explains it to me. I don't call some 1-800 number at Blue Cross Blue Shield and wait to get in a queue and call back. Michelle actively manages this plan. She's constantly talking to the pharmacy benefit administrator and the third-party administrator to manage the plan. That it takes a little more hand-holding because we are self-administered.
Well, and
Oh, are you saying
and that's what sorry. And that's, I guess, the culture of this organization. Hand-holding, it can sound negative, but it's just that one-on-one customer service. It's just, they're going, this is a very personal area of their life, and they are trusting you to help them. The last thing I want to do is have a 1-800 number call center where we have to send people to. That's not enjoyable for us. Christy is amazing at what she does, helping. She did your orientations, I believe, so you met her. The feedback we've gotten on her helping employees has been amazing. So we want to continue that level of service. And then you also think about when if you bring other people onto the plan, yes, opening that up for the risk, instead of having one employee that is hitting stop loss, we might have 20 employees that are hitting that stop loss amount. And then your stop loss renewals become unsustainable. But then you think about your own employees, the employees that we have here that are dedicating their time to Douglas County, and their costs are increasing because there's other people coming onto the plan. I'm not saying that's what's happening, but I'm just saying you don't want it to become where employees look at it like, well, if we didn't cover all these other people, maybe we wouldn't have to be spending this much. Not that we don't want to care for everybody, but I just think about things like that too, if that makes sense.
Well, that self-insured plan also does make it very much a community.
Yes.
And so how we think about community becomes really important.
Yes.
But it sounds like there might also be some reasons for us to move to other types of plans. And if an added benefit of that may be that we could extend some of that to other community organizations, depending on plan type and what that would all look like.
And also the marketplace has just really changed, for, an employer the size of Burt Nash and the health department, they might be able to get, you could find a decent plan.
You could do a self-insured plan for groups groups over 50, you can do a self-insured plan. Is it, expensive? Maybe. But when you get up to, 100 or more employees, it's, explore your own self-insured or self-insured plan and, see what comes back.
Commissioner Portillo, I think you said you had 3 questions. Was that it? Or just a couple of questions? I didn't want to.
Couple of questions. So the consolidated piece and then the even more consolidated piece, I guess, with the potential of other community organizations. So I guess those are really the 2.
I just wanted to give both Michelle and Sarah some feedback just from my viewpoint. I think, and in the past, one of the things is we have to make this decision early on about insurance, and it impacts our budget going forward. And then we may get additional requests from the very partners who we just increased their budgets for when it comes to insurance. I think it would I don't remember in the past if we've sort of broken out, like, this is how much we're paying for Burt Nash, this is how much we're paying for, extension, for township. I don't know if we've seen that and what those increases are. And I was really interested when I heard you say we can see, are their plans paying for themselves? I think that would be some powerful data to look at, and then have some really, quite honestly, some uncomfortable conversations with the heads of those organizations to say, look, are we just doing this because it's traditionally what we've always done? Would it be better for you to go get your own plan? And we'll put this much money towards your own plan, why because if we take it out of health, for Bert Nash, if we reduce what we're doing for them for benefits, they're going to come ask for it in another way. I mean, we're just going to, those bar charts are just going to move in the same directions, I think. And so I just think it would be good to have those conversations now and not in the middle of budget, when I think they get intertwined with other discussions. I think specifically, I'm thinking Douglas County Extension was one we've had that's been sort of an uncomfortable conversation in the past.
So let me share my screen just real quick. I know we're probably coming up on time, but can you hang on? Okay, can you see this chart?
Yes.
Okay, so this is
Make it a little bigger.
Yeah, if
Michelle.
you can make
Okay.
it a little bigger.
Yep.
Sarah's got better eyes than I do.
Yeah,
Is that okay?
a little bigger.
Okay.
Yeah, there you go.
Okay, so this is our dashboard that Willis does for us they do it for us every month. This is for the last plan year. So you were talking about, what are we paying for everybody? This shows, so if you look at the bottom left side, you can see the total cost, the accruals are what we actually, the funding, and then you can see the variance. So you can see if we just had, Douglas County employees on here, we'd had a $1.3 million surplus last year. We did end the plan, which I guess I probably should have mentioned. If you look, I don't know if you can, this number right here, we ended the plan last year. Well, no, we didn't. Nope, never mind. I haven't looked at this chart in a while. So, but I think this might be kind of what you were asking. What are they paying? What's the variance? So it's a good little snapshot.
Yeah, Michelle, that's the chart I was referring to.
Okay.
That sort of shows the difference between, and don't get very confused with the lives on this chart. The lives always get weird. So please don't pay attention to those.
Yeah, it's all
But
12
the total
months.
cost is like, yeah, it's like you get one life every month. It's
Yeah.
very confusing. So yeah, I don't know. It's the actuarials. So the total cost reflects the actuals of what they spent by division. And then the accrual is what did we charge them, which in essence, that would be both what we pay on their behalf as employer and what they pay on behalf as individual employees. And in every category in that comparison for that snapshot, everyone but Douglas County was in the red.
So I guess I was looking at these numbers. This was the prior plan year. We ended almost $1 million over what we projected. I mean, you can see why. This is actually last plan year. So we ended almost $1 million in the black. So it ended up being a good plan year last year. To add $1 million to almost $1 million to reserves, or whatever we want to call that fund. So that was good news. Everybody, most everybody did better.
And Michelle, that would probably explain the 9% increase that following year, right?
Right, you bet you. So if we can keep this up right here between, employee education and resources and plan design, I mean, healthcare never gets cheaper. We know that. I mean, the trend is typically between, 7 and 10% in medical cost alone. But so it always goes like this, but if you could have it going like this at a lower, at a lower rate. So
So I guess one of the things as we try to wrap up, if there are individual, items here as commissioners would like to know as before we move into exact plan renewal, both Michelle and I'd be glad to take those questions offline and comments offline so that we can really prepare for a solid plan renewal and then really get some additional information from commissioners about how we want to move forward when we come back in April.
This is Commissioner Portillo. I just want to reiterate what Commissioner Kelly mentioned, that it does make sense to have some of these conversations with our partners like Bert Nash and Public Health earlier rather than later. And I prefer for some of those conversations to happen before we get into the budget cycle.
Okay.
If we don't have anything else, I believe we can recess until our business meeting at 5:30. Thank you so much, Michelle. This was a really informative presentation. Really appreciate it.